Good morning, everyone. Thank you for joining us bright and early for our Wake Up with Research breakfast. So I'm Daryl DeWald. I serve as Washington State University's Vice President of Health Sciences. I'm also the Chancellor of the WSU Spokane campus. We're very excited to be back after September's event, which focused on health implications of wildfire smoke. It was timely and it was interesting. We started these research breakfasts virtually just over a year ago in response to the pandemic. And we decided to continue with this format as many of you gave us positive feedback that you enjoyed the morning events this way. Of course, being together in person is a great thing, and we hope to do that soon. But we will continue to do more of these Wake Up with Research breakfasts. So how did the Wake Up with Research series come about? We wanted to provide a backdrop for our community to learn more about the research that is happening right here in Spokane and across the WSU system. Our researchers are doing some truly amazing things and making important contributions in the fields of sleep and performance, addictions, autism, cancer, aging, chronic disease, neuroscience, and COVID-19, and the list goes on. So what is so great about all of this is that our researchers are discovering and working very hard through some complex and life-changing problems that will ultimately enrich the quality of life for me, for you, for all of us. With that, I want to thank our sponsor of today's Wake Up with Research breakfast, the Res Rudin Foundation. Res Rudin Foundation works with organizations and programs that encourage a healthy and productive life free from addiction. Here is their message.
Good morning, everyone. I am Marcia Malsom, the CEO of Res Rudin Foundation. It is our pleasure to be sponsoring today's Wake Up with Research on pain and addiction. The work you're doing at Washington State University has helped the Res Rudin Foundation focus on our goal of empowering communities to fight addiction. In our partnership with Wazoo's College of Nursing, Pharmaceutical and Pharmacy, and Research, we can work in our community to bring awareness about addiction and bring resources together to help those affected by drug misuse. The work done by Washington State University does help educate our community, so we're able to remove the stigma of addiction and address the real issues of drug misuse. Your commitment to education through research in this area makes a tremendous difference. It is evident that the faculty and staff at Wazoo are passionate about conducting valuable studies that address the complexity of addiction. While working with Wazoo's nursing interns, we have noted the high standards you have for your students while helping them value their education, as well as emphasizing the importance of being compassionate to those whom they work with. This is one of many reasons we highly value your university. We look forward to developing a long-term relationship with Washington State University in which we can help our community have a healthy conversation about addiction, as well as help those who struggle with addiction find a strategic and sustainable plan to have a lifestyle free from addiction. Thank you for your dedication towards this critical work. Your efforts are making an impact not only on campus, but also in our surrounding communities. I'd also like to say thank you to our presenters today for their time and effort. Have a great day.
Those were some great words from our friends at Res Rudin Foundation. A powerful message. We want to again thank you for your partnership with WSU and your continued support of this community. I'd also like to thank the presenters today, some amazing folks from our College of Medicine, Nursing, Pharmacy and Pharmaceutical Sciences, our College of Arts and Sciences, truly a dream team of researchers, some amazing people. And with that, I'm going to turn things over to my great colleague, Celestina Barbosa-Leiker, who is the Vice Chancellor for Research at the WSU Health Sciences Spokane. She's an associate professor in the College of Nursing, and she is going to lead us through our series of panelists this morning. So to you, Celestina, and thank you.
Thanks so much, Daryl. Good morning, everyone. It's great to be back again this morning with all of you here at the Wake Up with Research. As Daryl mentioned earlier, it's my hope that you not only learn about the great things going on here in Spokane, but also across the state of Washington. We have a couple speakers from the WSU Pullman campus joining us this morning too. So a great highlight of pain and addiction research going on across the entire WSU system. Before I start and introduce our speakers this morning, I want to talk about what got us here today, and that is WSU being a land-grant university and what that means to us. The land grant mission really calls for us to serve every resident in the state of Washington, and WSU Health Sciences Spokane not only helps educate the workforce, the future workforce for our state, but we also conduct research that helps to improve the health and well-being of every resident in the state of Washington. And our land grant mission plays right into our research topic today, as we will be exploring emerging health needs in vulnerable populations this morning. So the general topic here this morning is pain and addiction, and we have a very robust research expertise across our entire WSU system. The speakers that we have this morning is just a small representation of all of the great work that we're doing here at WSU on this topic. We are joined this morning by some fantastic experts on this topic across the entire WSU system. We have a lot to cover here on this topic. I know there's a lot of interest in this topic, so we are going to jump right in. So the first speaker that I want to introduce today is Dr. Carrie Cutler. Dr. Cutler is an assistant professor in the Department of Psychology here at WSU. Dr. Cutler's Health and Cognition Lab focuses on elucidating the potentially beneficial and detrimental effects of chronic cannabis use and acute cannabis intoxication. Carrie, over to you.
Thank you, Celestina. It's a pleasure to be here. So cannabis has been used for millennia to manage pain. In fact, Hua Tao, who lived around 200 AD, created the first general anesthesia out of a mixture of cannabis resin and wine. Even Queen Victoria used cannabis for her menstrual pain back in the 1840s. She also used it for morning sickness and obstetrical anesthesia during childbirth. Today, physical pain is the #1 reason that medical cannabis users report using cannabis. And in a recent large-scale survey of thousands of medical cannabis patients, we found that over 60% were reporting use for this purpose. Nevertheless, laboratory studies and clinical trials conducted with chronic pain patients suggest that cannabis produces rather limited decreases in pain. However, many of those studies used a single isolated cannabinoid like THC, the primary active constituent in cannabis, and many studies have relied on oral administration. Studies focused on inhalation of whole plant cannabis, especially high potency cannabis, remain rather rare, despite inhalation of high potency cannabis being the most common route of administration. And the reason why we continue to understand so little about the acute effects of cannabis on pain is because the current federal classification of cannabis as a Schedule I drug severely limits researchers' abilities to study it. So while pain patients and any other adult aged 21 or older can walk into a dispensary and purchase a variety of high-potency cannabis products, researchers must spend years applying to numerous agencies before they can administer cannabis to research participants in their labs. Further, until very recently, researchers have been required to only use cannabis from the NIDA drug supply for their research. The problem, as shown on this slide, is that the cannabis NIDA produces is not at all representative of the high quality, high potency medical cannabis that patients are accessing and using. And until recently, the highest potency cannabis they've produced is around 6% THC, Well, consumers are accessing products that can exceed 90% THC. We overcame these barriers by obtaining anonymous data from the medical cannabis app StrainPrint. This is an app that was developed for medical cannabis users to track their symptom relief and to identify the best strains and doses to reduce their personal symptoms. Users of the app rate their symptoms immediately before and immediately after using cannabis. We obtained data on over 5,500 medical cannabis patients using cannabis for headache, migraine, nerve, muscle, and joint pain. We only included sessions where patients were inhaling the drug. Collectively, this sample tracked changes in their pain symptoms across more than 150,000 cannabis inhalation sessions in their personal environments. The figures here show average pain ratings before cannabis use in crimson and average pain ratings after use in gray. They show 42 to 50% reductions in ratings of all types of pain after inhaling cannabis. While these results are encouraging, we also saw that ratings of the efficacy of cannabis for headache and nerve pain specifically decreased over time. And the dose of cannabis used to manage all 5 types of pain increased over time. And this suggests that users were developing tolerance to the drug over time. Limitations of this research include the lack of a placebo control group. And without such a group, it's likely that at least some of the pain relieving effects of cannabis can be attributed to the expectation that cannabis will help with pain. Further, there's a selection bias at play. It's likely that the sample overrepresents people who find cannabis effective at managing their symptoms, or they wouldn't continue to use cannabis or the app to track such use over time. These limitations are offset by some important strengths. First, this method allows me to bypass the US federal restrictions on acute cannabis research so that I can study actual medical cannabis patients using their own cannabis, often high potency cannabis, in their own homes. And that results in very high ecological validity. Also, participants are using the app to track and better understand the strains and doses that most effectively reduce their personal symptoms. And most participants would be unaware that the data are being used for scientific investigation. That would reduce any biases where participants would try to exaggerate the effects in order to portray cannabis in a positive light to the scientific community. And finally, I'll note that this is the largest study of its kind. Most studies of acute effects of cannabis rely on rather small samples that are tested once or twice, while the use of these app data allowed me to examine things on a much larger scale and over a much longer period of time. Thank you.
Thank you so much, Carrie, for sharing that research with us. It's absolutely fascinating. I know you've done so much here on the topic of cannabis use. And thank you also for highlighting the difficulties in doing research with cannabis too here. So I really appreciate that. Next up, we have Dr. Rebecca Kraft. Dr. Kraft is also a professor in WCU's Department of Psychology. Her research is currently focused on sex differences in the effects of psychoactive drugs, primarily opioids and cannabinoids, or THC. Today, she will speak about cannabis and whether it is the better pain reliever in women or men. Rebecca.
Thanks, Celestina, and good morning, everyone from Pullman, Washington. I'm very happy to be here today. As Celestina mentioned, my laboratory studies sex differences in the pain relieving effects of a variety of drugs. The reason we do that is that women suffer more pain than men. As you can see in this table in the left-hand column, it's a very long column, and this shows all the different types of painful conditions that occur with greater prevalence in women than men. So women have a particularly distinct need for safe and effective analgesic interventions, and So we are always on the lookout for classes of medications that may be particularly effective against pain in women. We use animal models to determine whether drugs differ in their effects between males and females. And I'm going to show you in this first graph what the differences look like in THC's effects between male and female rats that are either adolescent, young adult, or middle-aged. So what you're looking at here is 0% analgesia down here, all the way up to 100% or maximal analgesia at the top. And as you can see, when we give increasing doses of THC to these different ages of male and female rats, they show an increasing analgesic effect. But at all ages that we've examined, females show a larger effect than males do. Now, this is on the first administration of THC, but if any of you have chronic pain or you know someone who does, then you know that you can't, you're not going to just be using a medication every so often. You're probably going to be using it on a daily basis, and therefore maintaining the efficacy of the drug over time is really important. So we did a study to determine whether the efficacy of THC as an analgesic would be maintained over multiple uses. You're looking at a test, the same test here of heat pain on the left panel and pressure pain on the right panel. And here's the THC dose effect curve the first time THC is given to females and males. And you can see again that it takes less THC to produce the effect in females as it does in males. When you administer THC repeatedly for 10 days and then test its efficacy again, you can see the curves shift really far to the right, showing a significant loss of THC potency with repeated treatment. And that shift is much greater in females than it is in males. So females start out being more sensitive to THC's effects than males, but after repeated uses, they are either show the same response as males or they actually show a lesser response. So as Dr. Cutler suggested in her study in humans, tolerance does develop with, appears to develop with repeated use over time. And that could be a significant downside for females. Now, why are females more sensitive to THC? We know that one reason is that females produce more active metabolites of THC. This top graph shows you blood levels of THC from 30 minutes to 6 hours after a single injection. And you can see there are no sex differences in blood levels of THC. However, when you look at two of the common metabolites of THC, so these are chemicals that our liver produces in transforming THC, females are making a lot more than males. These are both active metabolites, hydroxylated THC and cannabinol, and that means that they produce all the same effects that THC itself does. So we think that females' greater production of these metabolites contributes to the greater efficacy of THC the first time it's used, and also contributes to the greater tolerance development we see in females. So in answer to this question, does THC relieve pain better in one sex or the other? Well, I've shown you that THC is more potent in female than male rodents, so that seems like a real positive. But I've also shown you that females are more likely than males to develop tolerance, and that could be a real downside. We've explored a number of mechanisms underlying these sex differences in THC effect, and I've shown you one of them today. Now, you may be wondering, well, this is all in rats, so what does that have to do with people? Does this really translate to humans? We think it does. Two pieces of data that suggest it does. One is that female humans also produce more of these active metabolites of THC compared to human males. And secondly, a recent study showed that when men and women use the same doses of cannabis, women experience more adverse side effects. And thus, we think the general advice given to women using cannabis as medication of start low and go slow is very appropriate. Thank you.
Thank you so much, Rebecca. That was a fantastic presentation. Thank you so much for covering all of that in a really great way. For anybody that has questions so far, we've had 2 presentations so far. Please feel free. Go ahead and put your questions in the chat there, and we'll be able to answer them at the end after we have all of our panelists give their presentation. So as questions come up, you don't have to wait till the end. Go ahead and just plop them there in the chat, and we have folks that will pull them all together, and I'll be able to ask them here this morning to our presenters. So please be sure to put your questions there. Our next presenter up is Dr. Mary Payne. Dr. Payne's longstanding research program, funded continuously by the National Institutes of Health, focuses on potential adverse interactions between conventional medications and natural products, which include botanicals and everyday foods. She currently leads the Center of Excellence for Natural Product Drug Interaction Research, a multidisciplinary effort involving clinical pharmacologists, natural products chemists, biomedical informaticists, and health communications experts. Today, she is speaking on a potential drug interaction with the emerging botanical product, Kratom. Dr. Payne.
Thank you, Celestina, for that nice introduction, and good morning, everyone. I'm happy to be telling you about one facet of our exciting research focused on natural product drug interactions. And specifically, I will be telling you about our latest research with Kratom. So what is Kratom, you may ask? Well, it is relatively new on the scene, at least in Western countries. It's been around for maybe 20 years in Western countries, unlike with cannabis, which has been around for ages, as Dr. Cutler mentioned. It is a plant that's indigenous in Southeast Asia. And it's been shown that at low doses, like around 2 to 5 grams, it acts as a stimulant. It is from the coffee family, and so at low doses, it's used as a stimulant. And in fact, the agricultural workers in Southeast Asia traditionally chew the leaves to improve endurance and stay awake. But at higher doses, it has been shown to have opioid-like effects. We're talking about maybe 5 to 8 grams. And so therefore, people often take Kratom to relieve pain and to treat opioid withdrawal symptoms. So this graph shows Kratom exposures in the United States from 2011 to 2017. And these are data that are actually obtained from poison centers. So very high amounts of Kratom were taken. As you can see here, from 2011 until 2017, that exposures rose significantly, and in fact, it was about 50-fold increase during this 6-year time period. These data raised attention from our Food and Drug Administration, and so they are very concerned about the safety profile of Kratom. It is not well defined, just like with cannabis, it's not that well defined. And particularly, the commissioner stated back in May of 2018, the FDA encourages more research to better understand Kratom's safety profile, including the use of Kratom combined with other drugs. So that's where we come in. And I'm about to describe to you a case report involving a patient with Kratom use disorder, and right in our own backyard. In brief, a 30-year-old man who was taking the drugs venlafaxine and quetiapine, both of these are antidepressants. He was taking these 2 drugs along with a very high amount of Kratom, 90 grams a day. And he was taking these to wean himself off of heroin. And it turned out it cost him about $2,200 a month to take this Kratom, 90 grams a day. He presented to the emergency department with symptoms of Serotonin Syndrome and QTc prolongation. So what is Serotonin Syndrome? Typical symptoms include high blood pressure, high heart rate, confusion, increased temperature, and he experienced all of those symptoms. And his electrocardiogram tracing showed QTc prolongation as an indication of an increased risk to a certain type of heart arrhythmia. So high concentrations of venlafaxine and quetiapine in our bloodstream can lead to the serotonin syndrome and QTc prolongation. So when he visited the emergency department, he was encouraged to discontinue venlafaxine and quetiapine. He was then referred to his primary care provider. And by the time he presented to his primary care provider, approximately four days, or 4 days before he was referred to my colleague's addictions clinic, he had stopped taking venlafaxine and quetiapine, shown here in the purple lines, and you can see that his symptoms had resolved. And by the time he presented to the addictions clinic research, he had the venlafaxine and quetiapine were very low in his body. And the good news, when he presented himself at the addictions clinic, he was amenable to decreasing his kratom use. So he was begun on a treatment with Suboxone, which is commonly used to wean patients off of opioids. And his SAOS score was 20. So what's the SAOS score? That is the subjective opiate withdrawal scale. You can see his score went from 20 to 0, day 5, after treatment with Suboxone. And by the time we submitted this case report for publication, I'm happy to report that he had abstained from kratom for 10 months and was doing very well overall. So this is a good news to this story, but I'd like to go back to these two drugs that he was taking, venlafaxine and quetiapine. I mentioned that very high concentrations in the bloodstream leads to serotonin syndrome and QTc prolongation. So we hypothesized that kratom in combination with these two drugs caused an interaction and therefore these dangerous symptoms. So that brings me to this pie graph that shows you a number of enzymes that are involved in the metabolism of drugs, or how we break down drugs. I'd like to point out these two enzymes here, which make up the majority of the pie: cytochrome P450-2D6, or CYP2D6 for short, as well as cytochrome P450-3A4/5, otherwise known as CYP3A. So these two enzymes are major players in drug metabolism, or how we eliminate drugs from our bodies. Here is a list of, just a short list of drugs that are metabolized by these enzymes, particularly opioids, benzodiazepines, and non-benzodiazepines, also known as Z drugs. This list also includes a number of antidepressants, including those two drugs that our patient was taking. So again, the hypothesis is that kratom inhibits the breakdown of these drugs, leading to increased concentrations of the drugs and potentially unwanted side effects, toxicity, or even death. And there has been death reports associated with kratom in combination with some of these drugs, most commonly the opioids. So my research group using our own data, we did find in vitro, using human-derived tissues, that is liver and intestine, where the enzymes are located, we did find that kratom was a very potent inhibitor of both of these enzymes. So we took our data along with other data in the literature and made some predictions about the interaction risks with drugs metabolized by CYP2D6 and CYP3A. Shown here on the left is our predictions for drugs metabolized by CYP2D6. We use what we call a probe drug, dextromethorphan. And dextromethorphan is a common ingredient in cough medications, but it is largely metabolized by this enzyme CYP2D6. So the point here is that we predicted a very low risk, and on the y-axis is a measure of risk. So the closer to 1, the less the risk. Our threshold is 1.25, which is indicated in this red dashed line. And you can see that the risk is quite low, up to doses of kratom up to about 8 grams. So at, quote, normal doses, like 8 grams or less, we predicted a low interaction risk for drugs metabolized by this enzyme. However, on the right, we can see that the interaction risk is much increased for drugs that are metabolized by the other enzyme, CYP3A. Looking at our threshold line here of 1.25, we can see that the interaction risk is well above 1.25 around this dosage range between 0 and 10 grams. But I remind you that our patient was taking 90 grams of kratom a day. So the interaction risk for that individual was very high for both of those drugs metabolized by these two enzymes. Well, predictions are just that. Is this really happening in people? So that prompted us to conduct a controlled clinical study in healthy volunteers previously exposed to kratom. Our clinical study involves two arms. The first arm is a relatively simple, where we enrolled 6 participants who were administered a well-characterized kratom product and a relatively dose, 2 grams, as a tea. That is a common route of administration. And what I mean by characterized kratom product, our collaborators, our natural products chemist collaborators, the University of North Carolina at Greensboro, they chemically characterize the product. They know all the chemicals in it, and they send it off for analysis to make sure that it's not containing any contaminants, to make sure that it's safe for human consumption. So we administer the tea alone to characterize the pharmacokinetics of various chemicals in kratom, a number of alkaloids. And what I mean by pharmacokinetics, that's the study of how we process drugs. So we absorb, we distribute, we metabolize, and we excrete them. And how do we measure that? We measure concentrations of our chemicals in our blood and urine over time to determine these pharmacokinetic properties. And because we know that one of the chemicals hangs around in our body for quite a long time, we collected blood and urine from all of these participants from 0 to 120 hours or out to 5 days. Now, the second arm of our study is the drug interaction piece. This one, we enrolled 12 participants. That first part of the arm, or arm 2A, we administered our 2 drugs, the 2 drugs that we studied in our in vitro work, dextromethorphan, which is metabolized by CYP2D6, and midazolam, which is metabolized by CYP3A. We administered the 2 drugs alone. To establish baseline pharmacokinetics, we collected blood out from 0 to 24 hours after administering the 2 drugs. After at least a 1-week washout, we brought the same participants back and we gave them the kratom tea along with the 2 drugs. Again, collected blood and urine from 0 to 24 hours, from which we will determine the pharmacokinetics of the 2 drugs as well as the chemicals in kratom. So that is the end of my talk. To summarize, the major kratom alkaloid, that is metragine, and using that as a marker of kratom, we predicted an increase in blood concentrations of the drug midazolam, which is metabolized by CYP3A, but not the drug dextromethorphan. And I'll point out that these are predictions based on a relatively low dose of kratom, that is 2 grams, and that is the dose that we gave to our healthy participants. Secondly, we have completed both arms of our study, and we are currently analyzing the blood and urine. So please stay tuned for what will undoubtedly be some very exciting results. I'm dying to see the results of this analysis. And finally, what is the big picture work of this project? Well, we hope that our results will provide direct evidence to regulators, healthcare providers, and consumers about the safe use of an increasingly popular natural alternative to opioids. And finally, I would like to thank my awesome research team for the great work that they do, our funders, the National Institutes of Health, and finally, all of you taxpayers who are the ultimate funders of our work. And I'm happy to take questions at the Q&A, and I'll hand it off to our next speaker.
Great. Thank you so much, Mary. That was a fascinating overview of your research, and it was great to learn about these natural botanicals, these natural products, and how that is interacting with other drugs potentially that an individual is taking. Thank you so much for sharing that work. If you have questions as they're popping up, be sure to put them in the chat, and we'll get to them at the end of the Q&A here. Our next speaker is Dr. Liz Wood. Dr. Wood is an assistant professor in the Elson S. Floyd College of Medicine, Department of Community and Behavioral Health here on the Spokane campus. Her focus is on her research focus is on opioids, chronic pain, disability, and the effects of the health reform. Over to you, Liz.
Thank you so much. So hi, as was said, I'm Liz Wood. I'm here to talk to you today about access to medication-assisted treatment for opioid use disorder in Washington State. So the good news is you need less science to understand what I'm saying, but the bad news is I still have a lot of hard words to say, so I'm going to do my best. I'll start with the main finding here, which is that within Washington State, the facilities and providers that offer medication-assisted treatment, or MAT, for opioid use disorder were highly concentrated in the Seattle-Tacoma-Bellevue metro area. Many of our rural Washington counties and our micropolitan areas had only 1 or 2 MAT providers, and we have some rural counties in eastern Washington that, for given MAT options, had no providers. If we're going to ensure access to evidence-based treatment for opioid use disorder, this is the gap that we're going to need to address. With that big picture thing in mind, I'll take the next slide, please. So a little bit of background for people with opioid use disorder. Methadone, buprenorphine, or naltrexone, using that to treat opioid use disorder is called medication-assisted treatment. It's a modality that's endorsed both by the CDC and the WHO. It decreases the likelihood of relapse and it reduces overdose mortality. It's greatly underused in the treatment of opioid use disorder. And the question, it's not for absolutely everybody, but it's certainly for more people than those who are able to reach it right now. So we have an access issue, we have an evidence-based treatment, and we have Washington State, which came early to the opioid crisis, which means in some ways that we're better equipped with the response that we've managed, but we still have limitations. I will take the next slide, please. So what I did with the help of a research assistant is go to our outstanding resource, the Washington Recovery Helpline, which in addition to having a phone number, also has a provider finder that compared to, for instance, there's the SAMHSA buprenorphine offerings provider database that is more slowly updated. We have an excellent one that's actually updated every month affirmatively by folks calling providers to say, is this something you're offering? So we used that resource to look up every Washington provider or facility that was offering methadone, buprenorphine, naltrexone, or Vivitrol for opioid use disorder. With our list of all these providers, I classified each of them within the census-based statistical areas of Washington. That sounds elaborate. What it just means is it's acknowledging the fact that, for instance, people in Vancouver might go down to Portland. People in Spokane might go north out of Spokane County. So within that, multiple practice locations for the same organization were counted in whatever CBSA they belong to. Next slide, please. So this is in late 2019, this data. And as you're looking at this map of Washington State, you'll see we have darker green for the metropolitan statistical areas, lighter green for micropolitan, and white for rural counties. There are major geographic differences in access to medication-assisted treatment within Washington State. So in late 2019, we had 26 facilities providing methadone. 16 were in the Seattle-Tacoma-Bellevue area. Several of our metropolitan areas, most of our micropolitan areas, and all of our rural counties were without a methadone provider according to that data. Take the next slide, please. There were very similar distribution patterns. Here I've shown you buprenorphine. It looked very similar for naltrexone and Vivitrol. Half of buprenorphine providers were in the Seattle-Tacoma-Bellevue area. Fortunately for buprenorphine, every metropolitan or micropolitan area had at least one provider who could offer this. The majority of the rural Washington counties, however, had only 1 or 2 providers who were offering buprenorphine, naltrexone, or Vivitrol. And on the east side, in counties like Lincoln, we had several counties that had a provider for maybe buprenorphine or maybe naltrexone, but not Vivitrol. So you could get 1 of these or 2 of these, but not the complete suite of them. Now, this does make a certain amount of sense that half of the population lives in the Seattle-Tacoma-Bellevue area. So it's logical that half of our providers are there. However, that's cold comfort if you are somebody in Lincoln, if you're in Wahkiakum and you're trying to get access to treatment and there's only one person and they may or may not be actually accepting new patients. They may not be in your network. They may not be convenient to where you can actually get treatment. So these reflect areas of concern in terms of access to this evidence-based practice. Next slide, please. So as a very simple articulation of where the providers are, this in some ways might seem intuitive, right? Of course, there's more providers over where there are more folks. What I'm trying to do with this Washington MatMap project, which is funded by the Alcohol and Drug Abuse Program at Washington State University, is to facilitate the stakeholders in a given area being able to understand what the needs are and what the resources are for their specific community. So I'm not intending to supplant or replace the provider finder for individuals who are looking for treatment. Rather, I'm trying to help us understand as we pick interventions to address the opioid crisis, as we pick interventions to help people in our community with pain, what resources do we actually have? What needs do we have? And how do we bring those together for evidence-based practice? So you're welcome to go to the website at washingtonmatmap.com, poke around, see what your community looks like. My next step is going to do the same thing all over again to see what it looks like in December of this year and to talk about the changes, because we've certainly seen a lot of changes as the pandemic has rolled out. We get more providers all the time, providers move. I'm interested to see how this has shifted over time, and we'll also be filling in with other information about, for instance, Narcan availability after the standing order was implemented in Washington State. So that is a very quick reference to take you through what's going on with access to medication-assisted treatment in Washington State. And like the other folks, I am happy to take questions in the question section. Thank you. I'll put it back to Celestina now.
Thank you so much, Liz. Thanks for sharing your work on treatment here. This is great. I know we already have questions coming in for you. Folks have been putting in questions in the chat. Just a quick reminder for others too as well. We've already got a great list going here for the Q&A session. Our last speaker this morning is Dr. Marion Wilson. Dr. Wilson completed her PhD in nursing here at WSU and the College of Nursing in Spokane within the Program of Excellence in Rural Mental Health and Substance Abuse Treatment. She is a board-certified pain management nurse. She's published research testing internet-based self-management programs to assist patients with persistent or chronic pain and those with opioid use disorder. Her current focus is on how adoption of non-pharmacological pain strategies can reduce harms related to opioids and address poorly managed symptoms that accompany pain, including sleep, mood disorders, and opioid withdrawal. Marion.
Thank you so much. What a pleasure to be here today to talk about some of the research. I've been fortunate enough to work with a number of people at WSU and in the community over the last 10 years or so, focusing on trying to improve pain care for people, primarily with chronic pain. Next. The purpose of the research program overall is to recognize that we know opioids work great for pain related to acute injuries, procedures, and pain at the end of life, but they also carry risks. Opioids can actually decrease in their effectiveness over time. So if you're taking them for a long period of time, you're probably going to need more and more to get the same relief. Not always, but for many people that does happen. And misuse can occur as that tolerance to the drug occurs over time, in that you may keep taking more or taking it as not as scheduled in order to get the pain relief that you wish to have. Also, opioid use disorder can develop in a small at-risk population of people who are started on opioids. Next. This study was done several years ago, funded by WSU Alcohol and Drug Research Program, and we tested an online program to help people learn pain coping skills using a self-management program for symptom control. We had tried this program in a chronic pain population and then realized that there was probably quite a bit of undertreated pain within the opioid use disorder population. So did another follow-up study. I really wanted to see whether the needs were being met for chronic pain within this population. We did find that majority of participants in our study reported that their first use of opioids was in response to a painful event. Now, this doesn't mean everyone who starts opioids will develop an opioid use disorder, but certainly when you're looking at a population with opioid use disorder, you will find a number of people that did get there first from having a painful event. We also found there was a high burden of pain, opioid withdrawal symptoms, and sleep disturbances within this population. Next. We followed up with some in-depth interviews of people in this program, and we learned a lot of really interesting things that have been the impetus behind a lot of future research that I've done based on what they were telling us. As one of the participants said regarding her pain, it was just like one of the hamster wheels. It seemed to never stop. My brain would tell me, you know, this pain can stop if you just go get pain pills. Another said, when it comes to opioids, you don't realize you're addicted until you try to quit. You're trying to not take them and you get sick. It's like having the flu because your whole body aches, a miserable feeling. So they talked about how they went from this appropriate use of opioids to manage their pain and then descending into a pattern of craving and ultimately having opioid dependence, where they were requiring that opioid to reduce withdrawal symptoms. And ultimately, it was often the intervention of a supportive person, a relationship in their life that got them into treatment for opioid use disorder. In some cases, it was a healthcare professional. In other cases, it was a friend or a family member. So they really emphasized for us here how important it is to have that trusted relationship with a supportive person to enter into treatment for opioid use disorder. And once they entered that treatment, they began to feel normal, as they said. They began to not experience the cravings all the time and the withdrawal symptoms all the time. So they saw it as a very positive thing. Next slide. So today we have a really interesting study going on with the support of the Race Routine Foundation and also the National Institutes of Health, giving us some funding to test how we can get people more access to non-opioid options. And in part, this was because we learned from our patients in opioid use disorder treatment that they were not offered a lot of options to opioids. They were given a prescription for their pain, and that was the first line of treatment. So we really want to flip that paradigm. We want people to think about things that we know can be very effective for pain early on. So in this study, I'm working with the Spokane Regional Opioid Task Force and a number of fantastic health and wellness practitioners in our community who are part of this study. And we're offering people an option of yoga, chiropractic, massage, or physical therapists to consult and offer some additional information about pain management. Now, initially, we were hoping we would do this all in person, but with COVID, we had to switch it to all telehealth, which was quite a disappointment. If you can imagine, a massage over telehealth is not going to be the same as it will be in person. But we also knew that our practitioners are so knowledgeable that we felt they would have information to give the participants that would still be of benefit, even if they couldn't have that hands-on experience they would prefer. So this study will be wrapping up probably in December, and we'll have more to share about that in the future. Next slide. Simultaneously, we've had some interesting studies going on, digging in a little more deeply to this issue of sleep disturbance within people on opioids. We knew from what the participants told us in that very first study with the pain self-management program that sleep was very disruptive for these patients in treatment for opioid use disorder. They were telling us that they were having very fitful sleep. They weren't able to fall asleep. They weren't able to stay asleep. So we partnered with the Sleep and Performance Research Center here at WSU campus, and we were able to get some people on methadone into the sleep lab. And what you see on the screen here in the colored figures are their sleep cycles. And you've probably heard about REM sleep being the most restorative, really important period of sleep as far as restoring cell cycle and keeping you happy and healthy. Well, you can see in red on the bottom, our healthy young adults have a lot of nice consolidated REM sleep that occurs throughout the night. This is what you would want to see. They also have in yellow, not too much wake time. So the yellow is the wake time. If you look on top of that to the methadone patients, you'll see a lot more waking time throughout the night. And you'll see the REM sleep does not look as substantial. In fact, there's a big gap there in the middle of the night where they should be having REM sleep. They're not having it. So we have this great quantitative information. We were also able to, again, with support from the Race Redeem Foundation, add to this study the use of sensors from the Smart Home Lab that Dr. Cook runs down in Pullman, and Dr. Shelley Friss, our partner in Vancouver. We put these sensors into the sleep lab so we could see if the sensors would help us see how people were sleeping at night. And that is a paper and a publication we'll have coming out very soon. But just in short, I will tell you, spoiler alert, we did find that the sensors were pretty good at letting us know what was happening with these opioid use disorder patients at night. So we're hoping we can find a more non-invasive way to be monitoring people who are at high risk to have overdose events, particularly when they're discharged from the hospital from an opioid use disorder treatment facility. So that's our ultimate goal, that we want to reduce harms related to opioid use within this population. Next slide. And then finally, we've been doing some really exciting work with the Spokane Hyperbaric Center. Dr. Stanek there and Drs. Layton and Dr. Raymond Kwok down in Pullman, who discovered with some rodent samples that hyperbaric oxygen therapy can be helpful with withdrawal symptoms. We know that it works in his rodents, and we brought some humans into the lab for 2 different studies, and it's also showing some encouraging results. We're going to try to test this on a larger population in the future, but we do have some small sample data to suggest that hyperbaric oxygen could be helpful. And certainly for people with pain, we know that hyperbaric oxygen has been around for a long time, very helpful with pain, but the addition of looking at the withdrawal effects is something new that we're doing here. So that's very exciting. So in the end, we know that managing pain, chronic pain, can be a long process for people to learn new skills, try different things that work for them. But we also know more and more that the brain can change its pain response. So just because a person has had chronic pain does not mean we cannot improve their life. We usually can in some ways. So I hope that people will feel hopeful if they're experiencing chronic pain, and I'm happy to accept any questions or comments that people have. And I will send it back to Celestina. Thank you.
Thank you so much, Marion. Great presentation. It's great to hear also how our sponsor, the Race Redeem Foundation, helps support some of your research as well. Thank you for sharing that. We are going to do a quick lightning round of questions. We have a lot of questions here for our speakers. I want to give everyone a chance to do just really quick answers if possible. And if we happen to run out of time, then we will make sure that the individual researchers get your questions via email, and they can be sure to answer them. So let's start off with an advocacy, a policy question. Dr. Cutler, this one's for you. Is there a need for any legislative advocacy to help research gain access to cannabis products with a higher level of THC?
Yes, absolutely. So there has been some done recently that's been very helpful. So as I indicated in my talk, until very recently, the NIDA drug supply from the University of Mississippi has really had a monopoly. And we've had to use cannabis from that drug supply, or researchers have. Now, the DEA has decided to change their tune, and they are now opening up other producers to get DEA approval to be producers for research grade cannabis. And that's going to help tremendously because, as I indicated, the NIDA cannabis is really not representative, whereas these other producers will be able to produce higher potency products that are more representative of what people are getting from the recreational dispensaries and medical cannabis producers. I'm Canadian, and cannabis is now legal federally in Canada, and it has not produced very many issues, but a lot of tax dollars. So I personally think that eventually it should just be descheduled entirely.
Great, thank you, Carrie. Dr. Payne, this one is about Kratom. And is Kratom regulated in any way? And is there a concern about it being sold out of convenience stores and potentially accessible to youth?
Yeah, so that's kind of a gray area right now. I will say that I would say back in 2016, so I mentioned the two, one chemical metragenine, and there's another one, 1-hydroxymetragenine or 7-hydroxymetragenine. They've been shown to cause the opioid-like effects. And the DEA actually back in 2016 were all intending to make it a scheduled drug, a Schedule I drug, just like with cannabis. But because of so much public outcry, they backed off. And so, crossing fingers, it's still not scheduled. And yes, and then the concern about it being sold in convenience stores, and I forgot to mention, it is sold at cannabis shops, even gas stations. I drive by the Ameripride gas station on Thor Street in South Hill, Spokane, and it's being advertised on their flashing advertising sign. And also I'm told that my family that lives in Oregon tells me that's sold at liquor stores. So it's very accessible. But yeah, in Washington, it's not regulated. Some states it is illegal. There's maybe 6 states that it's illegal, but Washington's not one of them.
Great, thank you, Mary. Rebecca, we have a couple of questions here. I'm going to try to synthesize them and see if you can tackle some of these. Do we have studies on the physiology of THC effect on pain? So receptors or pathways. And then another one in particular about if there's any data to ascertain the pharmacokinetics of cannabis on menstrual pain reduction.
Okay, first question, there is quite a bit of information at the cellular and sort of organismic level in animals on how cannabinoids are decreasing pain. The two main actions are on the nervous system, both the central nervous system and the peripheral nervous system. Cannabinoids can decrease neural firing. And then the second major mechanism would be on the immune system. So there are a lot of cannabinoid receptors on immune cells, and cannabinoids generally are considered to suppress immune, let's say, inflammatory aspects of the immune system. So there's kind of two ways that cannabinoids can reduce pain, since the immune response is very involved in most types of pain. What the second question about menstrual cycle?
Yes. Yep. The pharmacokinetics of cannabis on menstrual pain reduction.
I can say that nothing's been done in humans. We've done a few studies in animals looking at whether hormones will modulate that metabolism, and they do. So if you give females a male hormone, if we give them testosterone, their metabolism changes to more like a male. And if we give the males estrogens, their metabolism changes more like the females, and they show a bigger THC response.
Great. Thank you. Thanks so much, Rebecca. So I have a question here about potential for natural products for treatment for opioid use disorder. I might open that up to Liz or Marion or Mary. What are your thoughts on that?
I'll jump in first on this, that I think there's a policy answer and there's a clinical answer. And I'm going to leave the clinical answer mostly to those folks, except that as I understand it, we're still developing the knowledge base that we need to be able to figure out who these might be right for and in what circumstances. From the policy perspective, we have a big problem with stigma when we're talking about opioid use disorder. And one of the stigmas that we need to work on is the concept of replacing a drug with another drug. The concept of giving somebody who has had opioid use disorder another prescription to some individuals, to some providers, to some judges, to some communities feels counterintuitive, even though we're talking about very different experiences and very different quality of life for the patient. So when we're talking about replacing, or when we're talking about treating opioid use disorder with these natural products, it's, I think, going to be the same uphill battle to say, let's establish what we need to know clinically, let's figure out how to do this safely, and then let's break down some of the stigma around using something besides cold turkey abstinence as a way to deal with this issue.
Great. Thank you, Liz. Marion, I have one last question here. It is for you. You mentioned barriers to non-opioid pain management. What might some of those barriers be?
Well, the obvious one is always money, because a lot of the non-pharmacological treatments do cost money, and not all insurance companies pay for them. So if you don't have money to pay out of pocket and you don't have a good insurance policy that pays for it, you're probably not going to have access to it. Even people with insurance have trouble getting things paid for opioid and non-opioid as far as their pain management. So that's one of the barriers. Another barrier is just people's belief system and what they've been exposed to, what they've been taught about how to manage their pain. So if you have been taught have a pain, take a pill, if someone is going to come around and tell you there's some different way to take care of your pain, you may not believe that. It may take some convincing. And obviously it's a lot easier to take a pill than to go to a yoga class every day or to go to a physical therapist. So there are also the barriers of time, transportation, convenience, all of those things. So good question.
Great. Thank you so much, Marion. We are unfortunately out of time. I think we could sit here for another hour or two fielding questions. This is such a wealth of information and expertise from all of our presenters today. I want to thank you all for joining us this morning, and I want to thank these researchers, Dr. Marion Wilson, Dr. Carrie Cutler, Dr. Rebecca Kraft, Dr. Mary Payne, and Dr. Liz Wood. We truly appreciate your time and your insight this morning. We are going to continue our Wake Up with Research series. We want to let you know that our next Wake Up with Research will be January 27th at 7:30 a.m. This will also be a virtual event, so you all can attend from home or from your office. January's topic is going to be on animal and human health. So we are really excited to bring a great panel of speakers to you on January 27th. If you want to follow up with anything that was shared today, please feel free to reach out to me and I can point you in the right direction. We can follow up. There was a lot of questions we didn't even get to this morning from our viewers. So please get in touch with us and we'll put you in touch with our experts here this morning. I want to especially thank again the Race Rudine Foundation. Thank you for your continued support of research and programming here at Washington State University. Thank you everyone for joining us. Have a great rest of your day. We will see you bright and early in January. Have a great day and go Cougs.